Center. This is 22 News in Focus.
Good afternoon and welcome to 22 News in Focus. I'm Ciara Speller. October is Breast Cancer Awareness Month, and according to the Centers for Disease Control and Prevention, about 245,000 cases of breast cancer are diagnosed in women, about 2,200 in men every year in the U.S. Multidisciplinary team management of many medical conditions, especially cancer, plays an important role in patient care today. And multidisciplinary care of a breast cancer patient involves not only medical oncologists and surgeons, but pathologists, radiologists, and radiation oncologists as part of the team. The end result of their combined efforts is to improve the quality of life and increasing survival of their patient. Today on 22 News in Focus, we'll be talking with 5 doctors from the breast cancer team at Bay State Medical Center. They'll be discussing the integrated approach of each medical discipline that contributes to the breast cancer patient's overall care plan, as well as take a look at the newest advances in breast cancer care. Joining me now to talk about the team approaches are Dr. Holly Mason, Section Chief of Breast Surgery, and Dr. Grace McCarry-Judson, the Chair of Bay State Health Breast Network. Thank you both for being here with us today.
Thanks for having us.
Yes, thank you for having us.
My first question is, what is the Bay State Health Breast Network?
The Breast Network has been around for a long time, and essentially what it is a way for clinicians that are interested in the care of breast diseases and breast cancer to come together to form guidelines so that we have a seamless process for a patient from the time of an abnormal mammogram to diagnosis to treatment, and so that we can standardize care in a way that we can assure that wherever the patient is being seen at Bay State Health, that they're getting that same level of care.
And so, Dr. Mason, what services are included?
Actually, all of the services that you have here today. So we start with our radiologists, our surgeons, our medical oncologists, our radiation oncologists, and our pathologists. Both physicians, nurse practitioners, and nurses can be involved as well, because every single component is integral to providing the good patient care. And
Dr. McCarry-Judson, what is the team approach to cancer treatment?
We've been working as a team for, again, many years. We started our first multidisciplinary breast pathology conference 25 years ago. It was the first tumor-specific cancer conference at Bay State and in the region. And what it does is it helps us to really focus on the individual patient, to look at the films for a second opinion review, to look at the pathology, and to have all of the members of the team there as we talk about what are the options for this patient, what are the best strategies for care.
I think it's really important, that each patient is different, each cancer is different, and that creates many nuances to care. So if you take this, a similar patient, their care may be very different depending upon the specific circumstances. So it's very, very important that all members of the care team, discuss the options and be on the same page.
Right. And so, Dr. Mason, for you again, why is having a team of specialists so important to breast cancer care? And aren't the surgeon or oncologist the only doctors needed?
Absolutely not. So, I think it's very, one of the things that's changed in breast cancer, it is not one size fits all. And the surgeries that I choose could impact, radiation, medical oncology, and we really want to come up with the best plan for the patient. And as you mentioned, survival is important, quality of life is very important, and as new research comes out, the roles for each of the different specialties change. So from how to manage the breast, lumpectomy versus mastectomy, whether to remove the lymph nodes or not, indications for chemotherapy, radiation, all very, very different for each patient. And if your care provider, whether it's a surgeon or the medical oncologist, is taking care of the patient without discussing it with all the other members, decisions may be made that aren't, the comprehensive plan that you want.
Right, so how would you both say that this differs from treatment in the past?
Again, I think that it used to be the patient would see the surgeon first, the surgeon would decide on the surgery, would do the surgery, and then the patient would see the medical oncologist. Very siloed care, and actually most of our care now happens, across the spectrum and the continuum, kind of all at the same time. The patient may not know that's going on, that's happening behind the scenes. So again, the patient will hear the same story throughout the process.
Breast cancer is a rapidly changing area. There are a lot of advances, there's a lot of information, and so by working as a team, we're really playing off the benefits of what each of us knows from our specialty. And I think that helps us to be a very, very strong team.
And so, do men get the same treatment?
Men are treated similarly, but they're oftentimes diagnosed at a more advanced stage because men are not typically screened. They don't start mammograms at age 40 or 50, and usually it's identified when they feel a mass or their primary care physician or someone notices a mass. And so the options may be a little bit more limited from a surgical standpoint because of that.
Yeah, I mean, in general, the same principles are used for men as they are for women. For women, we often focus on trying to conserve the breast. For some men, that may not be an issue, but you know, we have had one patient in the past that was a swimmer, and he did not want to have a mastectomy scar, so he had breast conserving therapy. So the point is, both can be done, but it's just still an important discussion to have in terms of the advantages and disadvantages of all the options.
And let's talk a little bit more about, you know, breast cancer in men. I feel a lot of the time we talk about it relating to women, but it can affect men. So, you know, what should men be alert for?
Really any change in how the breast looks. So looking in a mirror is very important. If they noticed a change in the skin, if they noticed a lump, the overall contour is just different. If they see changes in the nipple or discharge from the nipple, it's something that they should seek evaluation for.
Remember, breast cancer in men is still very rare. 1 in 8 women will get breast cancer, 1 in 800 men. So the men that are at most risk are usually ones that have a family history or perhaps have other estrogen types of exposures that may put them at higher risk. So it's important to have an awareness, but again, still it's an uncommon situation.
And so let's talk about locally. You know, how many men and women will you treat for breast cancer annually?
Yeah, I mean, typically we see somewhere between 350 to 400 patients with breast cancer per year.
And that's both men and women
Yes,
combined?
all combined, yep.
While many are focused on their physical health, mental health plays an important role in a patient's recovery. Could you explain how this works in a patient's treatment plan?
Well, from the very beginning, we want to start addressing the needs of the patient, both physically, obviously, with the cancer, and psychologically. And it starts at the breast center, where we have nurse navigators who will be assessing the patient, doing distress screening, determining whether or not the patient will need more support as they go along the pathway of treatment.
You know, we have our own support services that we can offer through the Bay State Regional Cancer Program, but we also have a nice partnership with Rays of Hope, and there are a number of community programs that specifically help to address not just your physical health, but emotional and mental health and other aspects. So that partnership really helps.
And once someone has been declared cancer-free, is there a plan for aftercare with the team?
Absolutely, and we call that survivorship. And it starts, it's instigated from the medical oncologist and carries over for long-term follow-up, and we want to assess for how often they should be screened and their overall wellness and looking for long-term effects of their treatment.
I think one thing that's important to remember is that a woman is cancer-free after her surgery. So sometimes they say, oh, how long do I have to wait until I'm a survivor? Well, you know, right after the surgery, patient is considered to be cancer-free. And what we do is we will see them more intently over the first 5 years, but then once they may be done with some of their active treatment and they're really more on surveillance, that's when we will graduate them to our survivorship program, and they have the benefit of often seeing a nurse practitioner and having their mammogram on the same day, and that's something that is very satisfying from a patient's perspective, but from a clinical perspective, it allows us to stay in touch with the patients, to be sure to monitor them for any late side effects, to be able to assess them for any new health concerns, and also to emphasize the importance of healthy lifestyles and overall health in our breast cancer survivors.
And lastly, you know, we were talking about the patient, but you know, the families go through a lot as well. So what are some of the resources out there for the families?
Well, similar to the resources that there are for the patient, through Rays of Hope has numerous support services. There's also other local places that can, like Cancer Connection and Cancer House of Hope. So one of the things from the get-go when a patient walks in the door is we are assessing both the patient and their family. We provide them with written information about what is out in the community for them.
All right, thank you so much for that. And when we return, we'll be discussing how breast cancer is detected and diagnosed. You're watching 22 News in Focus. Today, we're talking about the latest diagnosis, treatment, and aftercare options for breast cancer patients. Joining me now from the Bay State Health Breast Care Team to discuss how breast cancer is detected are Dr. Holly Mason, Section Chief of Breast Surgery, Dr. Jennifer Hadro, Medical Co-Director of Breast Imaging, and Dr. Giovanna Creasy, Lead Breast Pathologist. Thank you all for being here with me. Our first question is for Dr. Mason. Have you seen a change in the extent of breast cancer over the last few years?
Do you mean in terms of the number of patients we've seen, or how big cancers are when?
Cancers,
Okay.
yeah, how big cancers
So
are.
actually, we're seeing fewer and fewer large cancers, and a lot of that comes from early detection. And our techniques with 3D mammography are getting better at finding smaller cancers. I think the primary care community, OBGYN, and patients themselves are much more aware of the breast disease and are finding things earlier. So I think that the trend has been that it's gotten much better.
And so even before that, are you finding that most women are finding, lumps and things like that themselves?
They do, and so we see a fair number of patients who do identify their own cancers. Correct.
And how important is a monthly self-exam?
I think it's important that a woman know her own breasts. Now, there will be changes throughout the month, especially with the hormonal cycles, but if you find a new lump, if it persists, it should be evaluated.
And Dr. Hadro, the next question is for you. Mammograms have been the subject of debate. What is a mammogram and what information does it provide?
So a mammogram is essentially an X-ray of the breasts, and it's a way that we look for changes in the breast, the contour of the tissue, and we try to detect cancers before they're felt is our goal with screening mammography.
All right, and Dr. Creasy, this next question is for you. Do you review breast pathology cases with other pathologists as a second opinion?
Yes. The breast cases are one of the most difficult specimens that we receive. Once radiology does a biopsy, then it's sent to pathology, and we process the tissue, we review the tissue. And frequently we review the cases together at a multi-headed microscope to come to the best diagnosis for the patient.
And so earlier we talked about, breast cancer in men as well. Can we just talk about some of the symptoms for both men and women?
Well, for many women actually do not know that they have cancer when they're diagnosed. And again, that's the impact of screening mammography to find a cancer before it becomes symptomatic. But certainly, cancer can form a mass. It could cause pain. It could cause nipple discharge. Sometimes women just notice a change in the contour to the breast or how the skin looks. So a wide variety of symptoms can occur, but we really prefer to find it before it's symptomatic.
And family history plays a role as well. So if someone has a family history of breast disease or cancer, how often should they be checked?
Well, it depends upon the level, and we call it risk assessment. We're determining what their level of risk is above the general population. I think that at least a yearly exam is indicated for any woman, but if someone is shown to be at an increased risk, it may go to every 6 months. We may incorporate other screening technologies to look at the breast. It really is very individualistic of how we approach that.
And so talking about screening, Dr. Hadro, there are now 3D mammograms. So how do those differ from 2D mammograms?
Well, the 2D mammogram consisted of two images, two X-rays of each breast in two different projections. The 3D mammogram consists of multiple images that are acquired through each breast in two different planes, and then they're reconstructed, so we actually can scroll through the tissue and look more carefully at the tissue. The problem, or one of the issues with 2D mammography, is that a lesion may be artificially created by overlapping tissue. Adding 3D means that we can actually scroll through the tissue and figure out whether a lesion is real or artifactual based on overlapping tissue.
Okay, and how about we talk about the stages of breast cancer? We hear different numbers, but maybe not everyone knows specifically what that means.
So it depends a lot. So just to go back to the screening a moment, once the radiologist has found a mass that is concerning, they will do a biopsy and they will come to us. And it's the pathologist actually. We don't see the patients up front, but we are in very close relationship with the patients in terms of looking at their tissues and making the diagnosis. The stages of breast cancer have a lot to do with, whether the tumor is still in the duct, and so in the milk duct of the breast, or whether it has already breached the wall of the duct and it is in the tissue of the breast and it's invading into the tissue. And then, so that those are already two different stages. And then also metastasis to the lymph nodes makes it an additional stage, and then metastasis to other parts of the body. But in terms of staging, there are different ways how you can stage. The staging nationally used staging system is the American Joint Committee on Cancer, which is together also with the College of American Pathologists and the American Society of surgeons and clinical oncologists. So it's all these societies that get together to build up a staging, and the staging is based on the characteristics of the tumor in the tissue.
It used to be that staging was based primarily on how big the tumor was, whether it was in the lymph nodes, and whether it had moved beyond to other parts of the body. Now it's much more complex because there are very specific characteristics of the cancer. If it uses hormones or has certain proteins on it, if other molecular testing is done that go into staging. And so it actually is a fairly complex process to sort out what stages. And the goal of staging is to look at prognosis. Ultimately, that's what we use it for.
And so does, a lump always mean that it's cancerous?
Absolutely not. There are many benign masses.
Yeah, about 80% of the core biopsies that we get are actually benign, and the rest is malignant, and then, yeah.
And I would say most patients even that present with a palpable mass, the vast majority of those turn out to be benign without even a biopsy, just when we see them as radiologists and work them up.
And so going back to the debate, with mammograms, if cancer does run in someone's family and they're, maybe a younger age than what's recommended for them, would they, be denied getting a mammogram if that's something they were interested in?
Well, we certainly don't deny people. It's just whether or not it would be appropriate. And it's like Holly had referenced earlier, it's a very complicated discussion and requires a lot of review of a patient's family history, including not just breast cancer, but other types of cancer, when the age of diagnosis. So it's a very complicated issue. And I think a patient should have a discussion with the doctor who knows her best, and decide whether she needs more extensive counseling with regards to risk, and then decide what type of screening she would need to undergo.
And can we talk about, non-invasive options? Because of course this can be really scary for people hearing that you have cancer.
Right, it is a very scary thing, and the good thing is that there are options for many patients. And it used to be everyone would need a mastectomy, that was all we had, and now we can do lumpectomies, we can hide our scars with the lumpectomy so there's a better cosmetic appearance. If someone has a tumor that is too big for a lumpectomy, they can see a medical oncologist and we can use medical therapy to try to shrink it. There are options for reconstruction, so it is a very different world than it used to be.
And what can be done for women who are pregnant or are being treated for other medical issues such as diabetes, high blood pressure, and heart disease?
Well, we find the correct balance, and pregnant women with breast cancer still absolutely can be treated. You can actually give chemotherapy if it's needed during pregnancy. There are surgical options. The one thing you don't want to do is radiation during pregnancy, but that's why you want the team-based approach to your care so that you can optimize treatment and get through the pregnancy as safely as possible. In terms of other medical conditions like high blood pressure and diabetes, those are very, very common medical problems and we deal with on a daily basis. And again, we find that correct balance to maximize, their patient's well-being, maximize treatment of the cancer and long-term survival.
And so what do you find that your, patients are most surprised about, or maybe didn't know about after hearing that they have cancer, diagnosis, treatment, things like that?
I think the thing that I hear from patients the most is they're surprised that their treatment isn't the same as their friends or their sisters or their mothers, that they may hear something completely different, but it is still the appropriate recommendation to them. It really just brings home the tailored care that we provide.
Yeah, it's all about personalized medicine. So a tumor doesn't fit all, as you said before, and so there are very different types of tumors, and depending also on expression of hormones and all the new molecular studies that are coming out make it very complex to diagnose and to treat breast cancer.
All right, thank you so much. Cancer diagnosis is life-changing, and after the break, we'll learn how a treatment team creates an individualized plan for each patient. You're watching 22 News in Focus. And today we're talking about breast cancer awareness, diagnosis, treatment, and aftercare plans. Joining me now from the Bay State Health Breast Care Team to discuss how treatment teams are created are Dr. Holly Mason, Dr. Grace McCaury-Judson, and Dr. Seth Kaufman, radiation oncologist. A cancer diagnosis, whatever the stage, can be frightening and confusing for the patient and their family. There are many unknowns that happen all at once, and there is a lot of medical information to learn. For some, there are sudden adjustments to lifestyle and living arrangements. So the first question is, what can a patient and their family expect?
First of all, they can expect that they will be cared for by a team. It will start typically with the breast surgeon and our team of navigators who help us in terms of assessing the patient. My goal as a breast surgeon is to talk with the patient and find out what's important to them, because that will play a role in determining what our plan is for surgery. I will discuss the pathology report. I will talk about the other pieces of treatment that are important, including medical therapy, radiation therapy, whether further imaging is needed, whether we need to think about genetic testing. So the breast surgeon will lay out a general process and a potential plan, and then I try to work through with the patient what their concerns are. Are they okay with the plan? Do they want to think about something else? And then I start making the appropriate referrals to the specialists when they're needed.
So basically a map of just everything.
It is a map of everything, correct.
All right, and Dr. Kaufman, how many specialists make up the team for a woman or a men's breast cancer care team?
So as we talked about a little bit earlier, it's the surgeons, certainly the medical oncologists, radiation oncologists, the diagnostic radiologists, the pathologists, and all of the members of those respective teams that work together to complete the treatment plan. And in my division alone, there's kind of a subspecialty there where you have radiation therapists, you have physicists, you have dosimetrists that will calculate plans, a lot of people that behind the scenes that are involved in the care as well.
And I think, when we talk about, all the specialists involved, we don't want to leave out our plastic surgeons because, many of our patients are concerned about how things will look down the road, and whether or not, plastic surgery is something that we can do or want to do may be impacted by the other treatments, not just surgery. And so, again, another member of the team that gets brought in when needed.
Okay. And what does a personalized care plan consist of?
So most patients will start out with surgery first, and then they'll come to the medical oncologist to talk about medications and then have radiation. But in some patients, that may be in their benefit to have chemotherapy first to shrink a tumor to make surgery easier. And so we may change the order around. So personalized care means that we not only look at the tumor and the molecular aspects of the tumor, we also look at the patient perspective and we look at the patient characteristics so that we can put together the best plan for that patient. And part of the assessment of this specialized care is not just looking at the size of the tumor and whether or not there's lymph node involvement, but looking at the molecular aspects, the estrogen and progesterone receptor, something called HER2/neu, which is a protein on the surface of the cancer cell, and that helps us to direct very specific treatment recommendations.
Did either of you want to add to that, or?
No, I think, Dr. McCaury-Judson did an excellent job summarizing what goes into the process. And so sometimes we don't always know, who needs to be involved. So some patients are very straightforward. They'll start with surgery and down the path. But others, we may, bring in a medical oncologist because we have a particular question. And then we realize, oh, we need our radiation oncologist. So some patients, the treatment plan I lay out ends up being a fairly accurate plan with all the referrals, and other patients it develops, and that can be overwhelming for patients because we just didn't know going in. But the important thing is at the end of the day that we have covered the appropriate bases to come up with the best plan.
Right, and how about nurse navigators? What are their roles?
So the role of the nurse navigator is to evaluate the patient, to see for stressors, whether they be social, family-oriented, work-related. They will help make sure that all of these pieces are falling into place and the patient is aware of all their appointments, that they're making their appointments on time. Some of our patients do go for chemotherapy first, but then need to come back and see the surgeon, and it's a very specific time frame. Our navigators are tracking the patient's progress through chemotherapy to make sure they get back to us. So it's kind of one point person for the patient and family to call with questions or concerns, and then the navigator, if it's not a question appropriate for the navigator, will contact the person it is appropriate to call the patient back.
And how often does a patient check in or consult with their team?
It really depends on what their treatment plan is.
Okay.
So for example, patients that are undergoing chemotherapy may be coming to our office every week, they may be coming every 2 weeks. We'll keep a very close eye on them. One of our goals is to help them to get through chemotherapy with minimal side effects and to help them avoid any potential hospitalizations from complications. So if they have a problem at home, they call our nursing staff and we'll get them in the same day to assess them to see if it's something that needs any kind of an intervention. So we have a very active, again, beyond just the medical oncologist, our nurse practitioners, our nurses, our practice nurses, our specially trained nurses that administer the chemotherapy. So there's a lot of depth in the team to help the patient get through.
Yep. And I think it's important to know with radiation that that is a daily occurrence, and so daily input and the radiation oncologist can check in with the patient at any point.
Exactly, yeah. So, with the different modalities, you do get this different timing of exposure with the caregivers. So on the radiation side, as Dr. Mason said, you're getting treatment anywhere between 3 to 6 weeks every day, Monday through Friday. You'll see a radiation therapist team that's taking care of you, setting you up on a treatment table. And once a week you'd see me or another radiation oncology physician and maybe a member of the nursing staff as well. So many opportunities to check in and see how you're doing in that situation.
And how about the patient's primary care or other doctors they might be seeing? Are they involved in this team as well?
We need to involve them in the beginning when we're trying to assess the risks and benefits of our treatment plan. So for example, from the surgeon's perspective, they want to know about the risk of surgery and operative risk. From our perspective, in terms of looking at giving them different medications, we want to know, is their heart function going to be a concern? So we will always keep them in the loop. But while the patient is going through the active process, for example, if they're going through 4 months of chemotherapy, usually the medical oncology group is handling all their day-to-day concerns during that period of time, because we want to be sure that something that they're experiencing is not a side effect of our treatment.
And what about other family members or caregivers? Are they involved as well?
When we recommend chemotherapy, we have what's called a teaching visit. And that's a visit that we strongly recommend that family members or other support people come, because that's when we say, okay, this is what this is what you can expect. This is what you need to take to minimize this side effect. This is when you need to call us. And the material can be so much to hear, and even though we give people written information, it's great to have an extra set of ears while you're going through that, because usually it's the family member. If somebody's having a side effect, it's a family member that might be calling as opposed to the patient.
And certainly with the surgical consultation with a new diagnosis of breast cancer, we recommend that a patient bring family or friends. It is so much information to go through, and very difficult to absorb it all. So we recommend that patients bring someone in who can act as a scribe, taking notes, or just be listening and answering questions.
Right.
Very important.
Overwhelming, so
Yes.
Good to know. All right. Some families have high cancer risk factors, and after the break, we'll discuss what those factors are. You're watching 22 News in Focus. Today we're talking about breast cancer awareness, diagnosis, treatment, and aftercare options with medical experts from the breast cancer team at Bay State Medical Center. With cancer, risk is considered the chance that a person will get cancer and the probability that the cancer will reoccur. Joining me to discuss high risks are Dr. Holly Mason, Dr. Grace McCary-Judson, and Dr. Jennifer Hadro. My first question is, what is considered high risk when it comes to breast cancer?
There are a number of things that can contribute to higher risk. Some benign breast disease can put somebody at a higher lifetime risk, and family history in particular can put people at a higher risk.
And if someone, whether a man or a woman, has a family history of breast cancer, should they consider genetic testing, and at what age?
So that's, again, a very complex question of which we have very specific, detailed guidelines. We ask the front line, the primary care doctors, the OBGYNs, to be sure that they ask complete family histories. And this is important, and that's to ask the mother's side and the father's side. Both make a difference. And to ask not just about one generation, but 2 or even 3 generations. And we're interested not only in whether or not family members have had breast cancer, but whether they've had other cancers like ovarian cancer, pancreatic cancer, prostate cancer in men, sometimes colon cancer or stomach cancer. And we're interested in the ages that these cancers may have been diagnosed. So all of that goes into a formula that helps us to assess whether or not someone meets criteria for genetic testing. So we ask the primary care providers to refer the patients to us. We have something called the Family Cancer Risk Program, and that's a dedicated team that includes a navigator, genetic counselors, nurse practitioners, medical oncologists. And what we do is we get all of these referrals. We get maybe 40 to 50 a week, and we look through them and we see who meets criteria for genetic testing, who should be seen for genetic testing, who maybe has a known mutation and should be seen by a medical oncologist, and we help kind of navigate their care. But genetic testing now is far more complex than what it was back when we started doing it, because there are multiple genes that we can test for. There are multiple tests and laboratories that provide those services, and the results need to be interpreted in the context of a specialist that really has expertise in helping guide the patient with the next decisions.
And so we've heard the BRCA gene. Could you, explain what that is exactly?
There are a number of genes that can lead to susceptibility to cancer. And so of 100 women with breast cancer, maybe 10 to 15 out of 100 got breast cancer because of a hereditary susceptibility. The 2 most common genes where we can see pathogenic mutations are BRCA1 and BRCA2, but now there are a number of other genes as well that we can test for. It is important to try to identify people as carriers, because that's our opportunity to prevent cancer. That's our opportunity to get people watched more closely in terms of screening. MRI is something we should talk about, how breast MRI is helpful in these higher risk populations. But we really want to give them a plan for what can you do to hopefully prevent cancer.
And would you like to discuss what that is, breast MRI?
Sure. So breast MRI is probably the most common supplemental screening tool that we use in addition to mammography. That's important to point out. It's used in addition to mammography. It's not a replacement. And it's the most sensitive test we have to detect breast cancer. It's not something we use in the general population because it does require injection of contrast material. It's a fairly long exam, about 45 minutes in the MRI machine, but it is the most sensitive tool we have. And in our screening population, we see a lot of the BRCA mutation carriers.
And Dr. Mason, do all women with a gene mutation need a double mastectomy?
Not necessarily, and I think this goes into which mutation they have, because each mutation has a different lifetime risk. Certainly the BRCA1 and BRCA2 patients are the ones that we see most commonly who want to discuss a double mastectomy. Some of the newer mutations that are being found, we don't actually really truly know what percent risk. And so with each patient, we try to go through the evidence that we have. What is the risk? How does the patient feel? Just because you have a BRCA1 or 2 mutation doesn't mean you have to have a double mastectomy. But if you choose not to, then certainly the enhanced screening pathway would be strongly recommended. As we've said all along, it is an individual choice.
And let's talk about the function of the high-risk team.
Well, as I mentioned, our Family Cancer Risk Program, we have a team that meets weekly and helps to decide people's potentially what test to do and who the best person in the family is to test. I want to come back to one more thing about breast MRI, because I think it's really important for people to understand that it's not just another MRI. It really requires specialized individuals, specialized radiologists that have the expertise in interpreting the MRI. And it also, if you find an abnormality on the MRI, you have to have the specialized equipment to biopsy it, because often you're only seeing it on the MRI and you're not seeing it on the mammogram or the ultrasound.
Did you want to add to that?
No, that's a very good point. right? So the patient should investigate carefully before they invest the time to have their MRI, that there is the capability of performing a biopsy and doing the appropriate follow-up care.
Okay. And what is the difference between absolute risk and relative risk?
We have these conversations all the time. So, I mean, the best way for me to explain it, so let me say that, so we have a medicine, tamoxifen, that can help lower an individual's risk of getting breast cancer. So it lowers the risk of breast cancer by 50%. So that's the relative risk. But the absolute risk means you have to say, okay, well, what is your risk of getting breast cancer? And if your lifetime risk of getting breast cancer is, you know, for example, in somebody that's at very high risk is 60%, you're bringing it from 60% to 30%, right? That's a 50% reduction. But if your lifetime risk is only 12%, like the average risk woman, then a 50% reduction of 12% gets you from 12 to 6. So that's when we talk about relative versus absolute risk reductions. And, you know, I think that a lot of times we are very interested in recommending treatments to reduce someone's risk, but the first part of the question is, well, how high is their risk to begin with?
And do you find that many patients know about that medication prior to, you know, coming in?
We actually have at least 3 medicines that are FDA approved for breast cancer risk reduction. Tamoxifen is in premenopausal women, raloxifene and anastrozole are used in postmenopausal women, and tamoxifen can also be used in postmenopausal women. In women that are at high risk because of benign breast disease, so they've had a biopsy that shows something that puts them at higher risk for breast cancer, we will very often make recommendations for those medications. For people that are higher risk because of family history, again, we're looking at a number of different options. Risk-reducing medication is part of that.
And who should get cancer screenings? What specific types and how often?
Well, I mean, you know, any woman should have, you know, breast cancer screening. You know, and what age you start at depends upon the level of risk, average risk versus high risk. You know, and I think that's part of the benefit of having a primary care physician is that they will, you know, monitor the screening of not just breast cancer, but colon cancer, other things, make sure patients are on track with having the screenings done at a regular time.
And what other risk factors are there that could lead to breast cancer?
So first and foremost, being a woman, since we said 99 out of 100 cases are in women and 1 is in men. Age is a risk factor. Age is a risk factor for all cancers, and breast cancer is no different. Hormone exposure. So estrogen is a big part of breast cancer risk. So the age at when a woman starts her menstrual periods, number of pregnancies, the age of the first pregnancy, and then the age where there's menopause. So in other words, the number of cycles. That's something that is potentially a risk factor. Postmenopausal hormone use can be considered a risk factor. Benign breast disease we mentioned. There are individuals that have had radiation to the chest for Hodgkin's disease. That's one of our success stories that unfortunately we found out years later that some of those young women treated between the ages of 10 and 30 may be at higher risk for breast cancer later in their lifetime. And then finally, I think, you know, what's really important, and we mentioned genetics, but then finally the other piece that's really important is lifestyle. So there is information that women that exercise regularly can lower their risk. Don't smoke. Smoking is not a big risk factor for breast cancer, but it is a risk factor. Okay. Alcohol is a risk factor. Some people may be more sensitive than others. Obesity in after menopause can be considered a risk factor. So a number of things that are potentially modifiable can be considered.
Okay. Thank you all so much for your insight. There have been many advances in breast cancer diagnosis and treatment, and we'll find out what they are when we return. You're watching 22 News in Focus. Today we're discussing the diagnosis and treatment of breast cancer with members of the breast cancer team at Bay State Medical Center. Researchers are always looking for better ways to prevent, detect, and treat breast cancer, and they're also looking at how to improve quality of life for survivors. Joining me to discuss the latest clinical advances in breast cancer treatment are Dr. Grace McCaury-Judson, Dr. Giovanna Creasy, and Dr. Seth Kaufman. So let's start with what improvements have you seen in breast cancer treatment?
I think one of the big themes of recent years has been de-escalation of therapy. So breast cancer years ago was treated with mastectomy almost everyone that had a cancer over a centimeter would get chemotherapy. Radiation was very common, hormone therapy in the appropriate patients. Now most patients are candidates for breast conserving surgery. There may be some situations where we can omit the axillary surgery, the surgery under the arm. There may be some situations, and I'll let Dr. Kaufman comment on some situations where we've been able to limit the radiation plan. From my perspective as a medical oncologist, probably one of the biggest improvements is the fact that we're able to better select those patients that need chemotherapy compared to those people that will benefit from hormone medicine alone. And so we've been able to dramatically reduce the number of women that need to have chemotherapy for early stage breast cancer.
Did you want to touch on that, the radiation?
Yeah, along those same lines, de-escalation has been part of the advances in radiation oncology, specifically for breast cancer. So whereas years ago we would always give, say, 6 weeks, 5-6 weeks of radiation in a woman's care, now it's very commonly 3 to 4 weeks for early stage breast cancers. There are situations where we've found that women who just had the lump of breast cancer removed, where years ago we would universally give radiation to reduce risk of recurrence elsewhere in the breast, there are situations of low enough risk where we can omit the radiation therapy. And so some of those advances have really helped us to, I think, improve quality of life, certainly by backing off on treatment when it's not really needed.
And I want to also mention that the reason that we're able to better predict about which patients need chemotherapy or not are advanced molecular tests that our pathologists can help direct.
And Dr. Creasy, what is the role of a breast pathologist in the multidisciplinary breast team?
Right, so as we discussed, the treatment starting from the oncologist and the surgeons need to have a diagnosis, and that's where the pathologist comes in. So we give all the information required to make a comprehensive decision and to tailor the treatment for each patient. And the information required is the type of tumor, the grade of the tumor, how big the tumor is it in lymph nodes, and most importantly is the expression of estrogen receptor and of certain receptor on the tumor cells, and because these expression of these receptors will lead to treatments with tamoxifen or with Herceptin in the case of HER2. Other things that we have is now also Oncotype DX. So a lot of patients, some patients will fall into the category that they can be their tumors can be tested even further to see how many more genes they have and whether they will or will not need chemotherapy, for example. And an additional test that we can send out and we evaluate the tumor for is Foundation 1. It's another FDA approved test where you evaluate the tumor on multiple genes of the tumor type, solid tumors, and that can then also guide the clinician to treatment.
Could you also explain the process needed to render a pathology report of a breast cancer and what is included in the report?
I said some of it already. What happens is that since we don't see patients, patients may not know what we do. So when a tissue is removed from the body, it comes to pathology and we process the tissue. Now, if it is a core biopsy, it can take up to 48 hours before the pathologist actually sees the slides. So what happens, we process the tissue and then we put some of the tissue on glass slides. We review the slides under the microscope and then we render a diagnosis and we do all the tests required, and ER, PR, HER2, these are all very important tests that are done up front. And that will guide the initial discussion for the clinicians and how to treat the patient. When there is more surgery done, like excisions of a lesion, then we look at the entire tumor and we give many more parameters. And the parameters that we give, all of them are very essential. And Dr. Mason touched upon, like the complexity of our pathology reports. And so that's something that is as treatment becomes more personalized, we have the complexity report becomes bigger, and so a lot of the time that the pathologists spend is with oncology cases and trying to give as much as possible information to the clinicians for treatment of the patient.
And Dr. Kaufman, how impactful is radiotherapy on a woman's daily life? Can she still go about her normal activities, work, exercise?
So generally speaking, yes. During radiation treatment, there can be fatigue, but it tends not to be impairing fatigue. It's noticeable. And there can be irritation of the skin in the area that's being treated, but otherwise, it really is a localized treatment. So that area of the body is affected, and most women are able to go about their normal lives and activities without too much impairment.
And what is the typical order of the three treatments, surgery, drug therapy, and then radiotherapy?
Yeah, it's a really good question because, as kind of alluded to earlier, there used to be kind of one set way. You'd start with surgery, you'd get your chemotherapy, you'd get your radiation, and now treatment has really become much more nuanced and personalized. And there are many cases where chemotherapy would be better given first to shrink a tumor and help the surgery to be more successful and maybe more limited. Radiation treatment, my field tends to be the last in the line of those treatments, but it's very important, though, that all the clinical members of the team, meet the patient at the beginning and really evaluate to make that determination.
And Dr. Makari Judson, how does a medical oncologist decide on the chemotherapy and medications needed to treat breast cancer?
Well, that's where we look very closely at our pathology report in terms of estrogen receptor, progesterone receptor, and this HER2/neu. And in the cases that are expressing HER2/neu, we give a monoclonal antibody along with chemotherapy. In cases, as we mentioned, that are estrogen receptor positive, we may send it for this molecular testing. So it is a complex process. We look at the tumor, we look at the anatomy, the size, we look at the molecular profile, but we also look at the patient. That's a very important part. We look at their overall health, we look at the goals of treatment, and we come up with a plan. And we will also look at any clinical trials that we have, and we will offer clinical trials to patients so that they know that there's state-of-the-art treatment. Many times in the people that are getting the upfront chemotherapy, there are a number of opportunities to be enrolled in clinical trials in the event that they meet the right criteria.
Okay. We thank the three of you for being here with us again, and we'll have the last word for you after the break. Stay with us. You're watching 22 News in Focus. You've been watching 22 News in Focus, and that does it for our program today. We want to thank our guests for joining us. We want to thank you at home for watching, and if you missed any of this, you can find it on our website at WWLP.com. From all of us here at 22 News, we wish you a great day.